Yes, good afternoon, and I know you had the briefing yesterday with Dr. Yaffe and Dr. Heyer, and they talked about some of the sobering numbers that we're seeing, and these are concerning numbers. I think with the modeling today, we're going to see a further update. We've been almost about every 8 days, 7-8 days with an update from Dr. Brown and from the team because things are moving that quickly. And I think that's a very important issue. We've been trying to raise this to your attention, that we are in very challenging and very concerning, worrisome times. They used the words yesterday, dire and scary. I would agree. And so with that, I'm going to first hand things over to Dr. Brown to take us through the updated numbers of where we are, and I think you will find them as daunting as others have seen them thus far, and I thank them for their ongoing work and for updating us accordingly. So Dr. Brown, over to you.
Thank you, Dr. Williams. So every second week, we share with you data that describes our progress against the pandemic. We present models that try to anticipate the likely course of the pandemic, and we try to paint a more complete picture of the pandemic's impact. Its destructive impact on our health system, the threat it presents to mental health, and the importance of schooling, even during the pandemic, for children and families. This week, we will focus solely on our progress against the pandemic, and our progress is both frustrating and frightening. I believe we are all feeling something similar right now. Whether we're working in a hospital, a warehouse, or a restaurant, whether we're a student or a retiree, everywhere, from my hometown of London up to Ottawa, from Windsor through to Kenora, I know some of us are frustrated, some of us are frightened, and some of us are just fatigued, and many I know are all three. After more than a year of fighting this together, we are now entering the hardest stage. Cases have risen, hospitals have filled up, and across Ontario, it is very clear we are very much in the third wave of COVID-19. And the numbers are still rising. But the biggest problem we now face may be that we're just too tired to notice. So I'm begging you as part of the team to notice. Notice that our hospitals can no longer function normally. They are bursting at their seams, we're setting up field hospitals, and we're separating critically ill patients from their families by helicoptering them across the province for care. Our children's hospitals are now admitting adults as patients, and this has never happened in Ontario before. It's never happened in Canada before. Notice, please, what is happening with vaccination. More people are getting vaccinated. We're about a quarter of the way through now the province's strategy. We're now focusing more on the people who need the vaccine the most, but the disparities are still there. The communities who need the vaccine the least are still getting more of it than the communities that need it the most. Our public health units are trying to prioritize communities to control the spread of the disease. This may be different in each public health unit, but please notice when it's your turn, and please get vaccinated. The vaccine protects you, and it protects the people around you. And the faster we get the third wave tamped down, the faster we open up. Notice when your friends, your neighbors, your children, or even your parents meet each other without masks. Notice if your workplace is open, but it shouldn't be. Notice if your workplace isn't safe. Notice the behaviors that we all know will put people in hospitals. In the same hospitals where we don't have enough nurses, respiratory therapists, or doctors to treat the patients. Notice that stuff and say something. It's uncomfortable, but it will save lives. Notice the places that have turned this around. One of them is right here in Ontario, Thunder Bay. Thunder Bay was the center of a huge outbreak only 2 months ago, but it's flattened its curve in an impressive way. The whole city came together, shut itself down, focused on the fight, and got it done. We all have to be like Thunder Bay, and we all have to do what we can do to reduce our contacts and reduce the spread of the disease. Notice California, which only a few months ago was suffering crises like the one we're starting to experience here, and which is turning it around. Not just because they have vaccines, because people went out of their way to get the vaccine. We have to get vaccines into each other's arms. There's no point in looking backwards right now. Notice that when you want to do that, and please look forward, because the going forward playbook is very simple. Here's our collective playbook. We need to keep the vaccine rollout laser focused on those Ontarians who need it most. We know who is vulnerable to COVID-19. They need the vaccine first. We need to keep workplaces safe. If we want to break the spread of COVID-19, only essential workplaces should be open right now. We need to stop infection coming into our essential workplaces to keep them open. This means people should not have to choose between keeping food on the table and keeping others safe by staying home. We need to support people so that they don't have to make that choice, and many people may need extra and easy-to-access support to stay at home when they're sick or they've been exposed to someone who is. This is true for cases and for close contacts. And we need to make sure that workplaces stay safe with enforcement. We need to limit, as much as possible, the entry of cases of the variants of concern. B.1.1.7 is now the overwhelming cause of COVID-19 in Ontario, but it responds to vaccines. There are more concerning variants around the globe and within Canada. We need to limit the spread of these even more concerning variants across our communities. This means limits on borders and on movement. Our playbook as individuals is just as simple. I know we're tired, I know we're demoralized, and I know some of us are heartbroken. And I know that all of us want to take a break. But hang in there, please, with these three things. Just these three things, because these three things will help stop the pandemic. Don't spend time with people indoors. When you do need to be inside to shop, to take transit, or perform other essential tasks, please wear a mask. When you meet people outside your household, meet them outside. And again, if you can't stay 6 feet away, always wear a mask. Get a vaccine when it's your turn. Help others get a vaccine when it's their turn. And wait for the vaccine when it's not your turn. That's it. Compared to the fatigue, the frustration, and the fear we feel, these three things are well worth it. They will help break the spread of COVID-19 until we can vaccinate enough people. The disease is complicated, but our playbook is simple. That is what the evidence tells us. It also tells us that the longer that we let this drag on, the worse it will be. And with that, let's get into the numbers. As we start to do the presentation, I'm sorry the sign language translation will disappear, but it will come back immediately following the slides. If we could put up the slides, please. Thank you. Let me start, as we usually do, with the key findings. So COVID-19 cases, hospitalization, and ICU occupancy are at their highest levels since March 2020, and variant cases continue to rise sharply. And when we talk about high levels of ICU occupancy, we're almost 700 today, and over 70 admissions yesterday. This level of ICU occupancy is compromising care for all patients, for all Ontarians who may need it. Ontarians can help themselves and others by limiting mobility to truly necessary trips and always wearing a mask and keeping 6 feet distance when in contact with anyone outside of their household. Although it's improving, vaccination is not reaching people at high risk fast enough to overcome the level of serious illness in our communities and our hospitals. And without stronger system-level measures and immediate support for essential workers and high-risk communities, high case rates will persist into the summer and perhaps through it. Let's turn to the first chart, which shows the rate of growth of cases across public health units in Ontario. You can see in virtually all of our public health units now, there has been substantial growth in the number of cases over the last 2 weeks. You can see that it has come down in a small number of public health units. This is largely due to strong public health measures being in place. And you can see as well here, I hope, that many of these increases over just 2 weeks are doubling of case rates. Test positivity rates are also increasing across Ontario. You can see here that the test positivity rate when we calculated it earlier this week was 8% for the entire province. Both the case rate and the test positivity rate are above the level that we used to call red or control, which gives us a sense of where we are as a province, that most of our communities are now in that level that we would be instituting very significant restrictions. And continuing, Ontario testing rates are flat. The increase in cases is because there are more cases, not more tests being done. When we see a stable level of testing, an increase in cases, and an increase in positivity, this tells us that this is a real increase in cases, and in this case, a substantial and sharp, essentially exponential growth in cases that we see in the province. Now, throughout the pandemic, we've talked a lot about the reproduction number, This is really a reflection of how many people are infected by every person who has a case. The higher the reproduction number, the more people who are infected. We talked about the greater transmissibility of the new variants of concern, the variants that were originally discovered in the United Kingdom, in Brazil, or in South Africa, and we've known that these were more transmissible. As you can see here, the reproduction rate for the variants of concern, which is in the left-hand panel in the orange chart, is well above 1. That's a sign of exponential growth. That means that cases are going to continue to grow substantially and rapidly for a while. But what's important is to note the right-hand side as well. The right-hand side in blue is the reproduction number for the earlier strains, for the wild-type variants, for the ones that were first identified in Wuhan in China. And you can see here that this reproduction number is also now over 1. So we're seeing a growth in the variants of concern that is dramatic and sharp. We're also now seeing growth in the earlier variants, which means that we are not really at the point yet of controlling the disease through the public health measures. Continuing on, this chart shows you the growth in hospitalization since the beginning of September last year and the growth in ICU occupancy. If you look over at the far left-hand side of the chart, you'll see that hospitalizations and ICU occupancy were very low in that lull period during the summer. This is a function of people completing their care, of people dying, of a variety of issues, but really we're able to empty out our intensive care units after the first wave. You can see in the second wave, the wave that really builds throughout November and December of last year and into the big bit of January, you can see that dramatic growth in hospitalizations that is accompanied a little bit later by a growth in ICU occupancy. But what's different now about the second wave, or what's different now about the third wave compared to the second wave, is that our ICUs, our intensive care units, never had the chance to empty out again. And so as we hit this third wave, as ICU occupancy rises, and remember the new variants of concern are not only more transmissible, they're also more dangerous. They are more likely to result in hospitalization. They are more likely to result in intensive care unit admission, and they are more likely to result in death. We're now filling up our intensive care units on top of what was still there following the second wave. And this is one of the reasons that we are in such jeopardy with our intensive care units. Let me turn now to the modeling, the projections of where we're going to be in the next little while with the pandemic. Once again, this is not one model that we're running here. This is 4 groups of scientists running different models with many, many scenarios. What we've tried to do here is consider what our likely trajectory would have been about 2 or 3 weeks ago, before the start of the public health measures. That's the red line. The yellow line here gives us a sense of where we would be with our current, or the ones that were announced most recently in terms of public health measures. That's kind of the moderate or the midline case. And then also what we would look like with stronger public health measures, perhaps more similar to the level of reduction in mobility that we saw at the beginning of the pandemic in April last year. And that's the green line. And you can see here as well a couple of other assumptions and variables that we tried to deal with. First, we're assuming here on all of these models 100,000 doses of vaccine a day. That's roughly where we are right now. We're also assuming about a 60% effectiveness in terms of stopping transmission, not in terms of reduction of mortality, not in terms of reduction of hospitalization. Those are higher percentages that we use in the models, but here, percent effective in reducing infection. And we're assuming it's a relatively random administration of the vaccine. The other thing that we consider in all these is how long the public health measures last. The solid lines are for 4 weeks, and the dotted lines are for 6 weeks. As you can see here, had we not instituted the public health measures, the models are suggesting that we would have had a much, much higher rate of case growth, to an almost unbelievable level of perhaps 30,000 before it would peak and come down. What the models are suggesting now, looking at where we are more likely, which is the yellow line, is that the case growth is going to be much less substantial. And if public health measures extend for 6 weeks instead of 4 weeks, we really blunt the second round of growth as part of this wave. You can also see with stronger public health measures and a longer, that dotted green line, a longer period for them, for 6 weeks, we actually would get down to a much, much, much lower level of cases, much similar to what we would have seen during lulls between the waves, rather than what we're seeing now. I also want to note here that we've been looking at the briefings from previous weeks. The red box here indicates the range that we anticipated in the last briefing, and all of the models are in line with what we would have predicted in the last time. Before I move on to the next set of notes, I do want to note that the goal here is to flatten the curve as much as possible, to push that curve down. Every time we hit one of those milestones where we're starting to control growth, where we're starting to flatten the curve, that's a cause for celebration. That's an indication that we're getting closer to a more normal summer. It's a goal I think that everyone can kind of work towards, and we actually are able to see our progress almost on a daily basis of whether or not we are or not flattening this curve. If we go to the next scenario, I know that there's a lot of attention on vaccination. We took a moment to consider what it would look like if we had about 3 times as many vaccines being administered on a daily basis in the province that we have right now. So although we are not administering 300,000 vaccines a day right now, we did consider what would happen if we started administering 300,000 vaccines a day today, Friday. You can see, I think, a couple of interesting things here. Even under the weak scenario, that earlier scenario that we're no longer on that trajectory, that red scenario, it brings the peak down, it shifts the peak to slightly earlier, and it brings down overall the total number of cases. If you look then at that top yellow line, that top dotted yellow line, that's the moderate public health measures. That's where we think we're at right now in terms of the effectiveness of our current bundle of measures. That top line is a 6-week imposition of those measures. If we had 300,000 vaccines a day, starting today, you'd see that line drop further, and you'd see a lower peak and an earlier peak. And it keeps on coming down quite nicely. And if you look at green, which is the stronger set of public health measures, again, with the assumption that we did have 300,000 vaccines, which we don't have right now a day to administer, that peak is earlier, lower, and the whole curve gets lower. So public health measures make a significant difference and have already made a significant difference in what we would see in this pandemic. Longer public health measures help really tamp down that curve and make sure that we get the cases under control. And more vaccines, if possible, actually add significantly to both the help significantly with the duration of this wave and the overall trajectory in the long run. Let me talk about what these different models now go back. I think we've lost our slides. If we can, thank you. Let's go back now to the ICU projections. So here again, we're assuming 100,000 doses of vaccine a day. We're assuming that patients are following normal protocols and entering intensive care units when they need the care. We're at about 690 patients in ICUs today. We had about 74 admissions to ICU yesterday. You can see that we're really growing at a very steep pace right here, right now with our intensive care unit occupancy. And we're starting to get to that very sharp part of the curve where growth is significant. Under any of the scenarios, I want to point out right now, under any of the scenarios, growth keeps on for the next 2 weeks. Whatever we have right now in terms of cases is really baked in terms of what happens to our intensive care units over the next 2 weeks. But you can see, if you look at the insert, that stronger and longer public health measures do help push down the overall target that we could hit. But over the next 2 weeks, it's likely that we will exceed 800 patients in intensive care units. That is well above the old threshold that we discussed of about 300. We are on track over the next 2 or 3 weeks to actually hit almost 1,000 patients in intensive care units. And unless we're able to break that, we could actually see higher and higher levels. Now, it's not clear that all those patients would ever be able to enter an intensive care unit bed, even with the heroic efforts going on across the province to increase capacity right now. There may just not be the ability to put them into these types of beds. And not only that, there may not be the ability to put other types of patients into beds who require intensive care. So we are right now at a very significant point of growth in intensive care unit occupancy. Let me talk now a little bit about what's driving this growth in intensive care unit occupancy, what's driving the growth in cases, what's driving the growth in hospitalizations. This slide describes mobility. We'll go through 2 slides on mobility. This is really based on publicly available cell phone data. We're able to understand when people are outside or a good distance away from their home. You can see here that following the public health measures around the winter holiday, you can see there's a substantial drop in mobility and it stays low for a while. This is really the result of first, people staying home around the holidays, but as importantly, the public health measures, and although they persisted for a while and were frustrating and challenging, you can see that they helped tamp down the level of mobility substantially and really brought it below a mobility threshold, that dotted line there, which is necessary to prevent spread of the pandemic. You can see, though, as public health measures have relaxed, that mobility has increased again substantially. And anyone who is looking at one of our major streets here in Toronto or commuting back and forth from work on one of our major highways is probably able to see that increase in mobility very easily. And although it is starting to come down now with the new public health measures, you can see that curve coming down on the far right-hand side. It's not down far enough to control the spread of the pandemic. On this next slide, you can see we've decomposed some of this change in mobility to look at places where people are often indoors, workplaces, retail and recreation, and transit. And you can see basically the same pattern again repeated. A drop around the holidays, followed by an increase, and then eventually an increase above a level that's really necessary to sustain control of the pandemic. And then just the start now as well of it coming back down, which hopefully indicates that the public health measures are starting to work. But we're not yet at that level of mobility at this point in time that would allow us to really control spread. There is other mobility data, but we're focusing on indoors here because that is where the majority of spread happens, is indoors. Continuing on, you can see the impact on the health system continues. We're now at a backlog of surgical cases of almost 250,000 since the start of the pandemic last March. That is a huge volume of care that is delayed or postponed. With the slowdown in care that you're seeing now at hospitals across the province, this is going to increase, and we expect that rate of increase will actually be faster and more dramatic despite efforts to try to maintain access to care. Looking here now, we can turn to vaccine progress, and this is where we have some good news in what's going on. The strategy is about a quarter of the way through. In fact, it's more than the 24% through that we're presenting here. This was calculated a few days ago, and it's actually increasing now over time. If you look at the far left-hand side of the panel, that's the bar or the part of the bar chart for older people. This is over 80, and you can see that it's almost blue, which is people who've either had a first dose or made an appointment for their first dose. And there's only a small bit of yellow left, which is people who've not received their first dose. Moving to 70 to 79, you can see again it's a substantial number. The vast majority of people have received a first dose or are booked now for their first dose. But when we get to 60 to 69, you can see that actually it's only about half have either received their first dose or been booked for it. And then looking over at the right-hand side, you can see under 60, younger people in the province, this is a substantially lower amount of vaccine that's been provided and taken. Moving on, you can see here the same chart as we presented last week. In this chart, it's worth just taking a second to kind of work through it. We're comparing neighborhoods by how high the rate of COVID-19 is. So one, that far left-hand side column, one is the highest risk neighborhoods. 10, the far right-hand side of the column, is the lowest risk neighborhoods. The first row is the oldest group of Ontarians we're looking at here, which is over 80 years of age. The bottom row is 16 to 39 years of age. You can see that we actually had a very, very large discrepancy between the lowest risk neighborhoods and the highest risk neighborhoods when we presented last time. This has started to narrow. However, it's important to note that still it is 82% of people in the lowest risk neighborhoods who've received a vaccine. It's only 65% of people in the highest risk neighborhoods who've received a vaccine. And so that is a difference that needs to be closed, and actually we would hope to see more people in the highest risk neighborhoods having received a vaccine. The picture actually is improving, though. That's a smaller disparity than in the past. And as we start to move down into younger age groups, you start to see the type of difference that we'd like to see. Say, for instance, in the age group of 70 to 74 years of age, 57% of people in the highest risk neighborhoods have received the vaccine. 39% of people in the lowest risk neighborhood have started to have received the vaccine. And so that's the sort of difference that we want that will really help control the spread of the virus in the highest risk neighborhoods. That picture continues on for a while through some of the middle age groups, but you can see as we get into younger age groups again, that disparity emerges again. For instance, in age 16 to 39 years, 5% of people in the highest risk neighborhoods have received a vaccine, whereas 10% of people in the lowest risk neighborhoods have received a vaccine. And so it's important to keep on correcting that level of disparity. Now, moving on to our last slide of results. If we took about half of our vaccine and we focused it into these highest risk neighborhoods, it pays a substantial dividend in terms of control over the pandemic. And so we're considering here a vaccination strategy that is at about our current level, at about 100,000 vaccinations a day. We're thinking about putting about 50% of vaccines into the 20% highest risk neighborhoods. And you can see that it actually provides a substantial improvement in control over cases compared to allocation of vaccines based on age and population size alone. And if you'd like to think about the number of vaccines you need to give to stop or avert a case of COVID-19, if we just do an age-based allocation across the province, it takes about 60 vaccines to avert a case. And instead, if you really focus it in with about half those vaccines in the highest risk communities, it takes about 30 to 35 vaccines to avoid a case. And so a very, very big return if we're able to continue on with this focus of vaccines, as is indicated in the phase 2 of the strategy, focus in on high-risk communities as much as we can. I'll finish here with our key findings, as we always do. If maybe we could return to the slides. Thank you. COVID-19 cases, hospitalizations, and ICU occupancy are higher than they've ever been before. ICU occupancy is compromising care for all patients. Ontarians can help themselves and others by limiting mobility to truly necessary trips, always wearing a mask, always staying 6 feet distant from anyone who's outside their household. Vaccination is improving, both in its rate, or its volume, and in terms of its focus on the areas where it'll do the greatest good. But we're not moving fast enough yet to overcome the level of serious illness in those communities, and that is in our hospitals now. And without stronger system-level measures and immediate support for essential workers in high-risk communities, these case rates will persist. I'm moving on here to the contributors. These are the scientists and experts from across the province who've contributed to the material in this briefing. And I could spend a lot of time just calling out their volunteer work here. I'll also note that there's about 120 scientists who serve on the various tables right now providing advice, and I'm really grateful for what they provide every week. And with that, Dr. Williams, I'll turn it back to you.
Well, thank you, Dr. Brown. And as we've been going through the last number of weeks, and today especially, we're seeing the extreme concerns, and the modeling data supports that, of what we're facing today and in the weeks ahead. And we continue to take and value the advice of the science table as we try to look at implementing and dealing with the aspects of how to respond to this in that. And I know later on today we'll be making some more announcements on that in this afternoon. Yesterday, Dr. Heyer and Dr. Yaffe spoke about the update with the data, and it was sobering even before we had the modeling. So the real data supports the modeling as well. And they're talking about dire and scary and the aspects there. I think that's one aspect I hear often referred to. People say, well, why can't it be as good as we saw people doing back in March of 2020 when we had the first wave? And a big difference I hear then and now is that people were more concerned, worried, fearful at that time than they are now. But from the modeling data, and as Dr. Brown's alluding to, there is real necessity to be worried and to take apprehension and the aspects of there seriously. And so we're looking at that. If we look at our data for today, we have 4,812. We could actually top 5,000 before the weekend, and that is consistent with the modeling data. There's 1,955 patients in the hospital. And we have, in my data here, it's over, just as Dr. Brown said, 700 in the intensive care unit. Our positivity rate has gone up with the tests done today, 64,304. While that's more than the last few days, it doesn't have the pattern in the past. We would sometimes shift up to 70,000 to 80,000 tests, but we're staying consistent with the number of tests, but the positivity is going up. And so therefore the rising numbers, as Dr. Brown has alluded to, is not a matter of more people getting tested, but in fact the positivity rising up to 8.2%. That's down from when we peaked earlier in the week, close to 10%. We're down a bit, but that is a lot higher than we experienced in the past. So that means we expect the numbers to rise and go up again tomorrow. In our cases in Ontario, when we look at across the whole province, our rate per 100,000 has gone up 37% in the 1 week only. And we're at, for the Ontario average, because people seem to think it's more about one area and another area, the overall average for the province is 186 per 100,000 people. A few weeks ago, we were just around 100, and 4 or 5 weeks ago, we were under 100 for the province. That's how fast things have progressed and changed. So that tells us what the variants are making an impact. And as Dr. Brown's alluded to, that they now make over 70% of our samples being submitted. And of those 70%, the majority by far is the B1.1.7 or the UK variant that continues to have havoc. But that brings a point in hand, is that unlike the first and second wave, we're actually dealing with 2, maybe 3, hopefully not 4 separate epidemic curves going on. That's a new challenge for us. We have still the COVID we had before is still causing outbreaks and major cases in various parts of the province. Some have only those at the moment. Others, they're seeing the great impact of the B1.1.7, and that's leading to huge numbers, outbreaks, and hospitalizations. But we're also seeing a rise, small yet, but worrisome, of the P1, the so-called Brazilian variant, that is having impact as well. We're trying to keep it contained. Thus far, the B1.135 is staying, the South African variant is holding, but it doesn't mean we can take it for granted. So we have these events going on at this time. That is different than we did in the first wave and the second wave. And as Dr. Brown has alluded to and said many times in the modeling data, the relative risk of these variants over the older version of COVID is much higher. Higher for admission, higher for ICU, and higher for mortality. And affecting younger populations with much less of an inoculum or virus load, causing infection very quickly in short intervals and having much more rapid onset, and now impacting younger and younger populations in our society. So it means everyone has to take really strict adherence to the measures. One of the things that Dr. Brown's alluded to in his charts there, he talked about mild, moderate, and strong public health measures. And those are very critical. All along, we put public health measures in place, and there's 2 things, and we've asked that, what's the difference between those? Some are ones that only do a little bit and ask for more and ask for more. That's one metric of mild, moderate, and strong. But the other aspect is, what is the adherence to those measures? If people don't, it's a mild one. Even no matter how strong you make it sound, people don't listen. If you do moderate, a good amount are. If you do strong, everyone does. So it has to be both sides here. We both have to do our part on this one here. And the other epidemic I'm talking about and I'm seeing over the last while is that as we've done and we've had ability to keep our deaths down and to keep our cases down thus far, there's been a sense among the public that this pandemic really is not such a big deal. Nothing could be further from the truth. And sometimes people say the measures that we have to do for strong control are more bothersome to me than the fear or concern of getting COVID. You may have felt that from the first or second wave. You should not feel that way with the third wave. And you really have to take this seriously now. So we need to turn that back for those that are saying, I'm going to do my own assessment and decide what I want to do and don't want to do. I really can't emphasize more strongly right now, do not do that. Stick to the measures, because you really can't assess your risk situation in your behavior unless you follow the public health measures, as the science table and Dr. Brown and our public health measures table continue to emphasize. So we have to do that. So that's that aspect around 2 things. 1, sticking to the measures, the masking, the distancing. Listen to our new directions on how we're going to ask you to be very strict on this. We're trying to do our part to make sure those are strong. We need you to do your part to make sure they're strong. And then the other aspect is your mobility. If you don't need to go out, don't go out. If you don't need to go wandering around, don't go around, because you not only risk getting exposed, if you might have been exposed, you risk to bring to other areas that haven't got the same impact. So you have to be considerate of one another, encourage one another. Maybe not wearing the mask, to say and politely, you need to wear that mask properly. In a household, you really can't come in the house. I'm sorry, not at this time. So we want to do it in a way that we respect each other, because this is a community-wide response. The other part, as mentioned by Dr. Brown, is the vaccination. And the vaccination, our challenges, we would like to have a lot more vaccine than we've got. If we had as much vaccine as we have, we could be doing well over 500,000 doses a day. But that's not the reality right now. And we would have liked to have it higher all along. We're trying our best, along with our federal counterparts, to get that up. But when you wait your turn and you get in the line to do that, because we want to make sure everybody gets done in the right way. We want to do our high-risk people first. And in some of our high-risk areas and neighborhoods, we need a community interest in that. There are people in there that are not sure where to go. They're not sure how to get it sometimes. Sometimes it's technology. And sometimes there is some apprehension. There may be some language issues. There may be some cultural issues. And we're saying as a community in that area, when we identify as a high-risk area, do your part as a community member. Encourage your fellow community members. Go out and get vaccinated. We will help you to get vaccinated. We will take you to the place to get vaccinated. We will help you to register on the online COVAX system, because there's lots of younger people out there that say, it may seem hard to you, but I can get you registered. I know how to do it. And if there's problems and issues, we want to know how to solve that. So that's a community response at the same time to make them strong. So we need to be strong in our measures we're asking. We need to be strong on how we are seeking to enforce them. We need to be strong on how we as individuals are adhering to those measures, encouraging each other with kindness and respect to adhere to those. And we need to be strong on our vaccination to make sure that we're encouraging ourselves individually and as a community to put those aspects in place. So by doing that really stringently over the next number of weeks, as the data has shown, and we've seen that the science table has adjusted as they've seen the changes in the agents, that means the viruses, the changes that we talk about in the people, in their immunity and vaccination impacts, and the changes in the environment around how people are acting and behaving in the more milder and warmer weather in that. And they keep modifying those and advising us how we're doing and how we need to move more stringently in this area or that area in our part to bring it down. But that's also advising you, as of today, what you need to do, each of us, individually and personally, because we can do this. We've did it before and we can do it again. We need to do it for many reasons. One, we've now had to close our schools. We did not want to do that. We don't want them closed. And that's having huge impacts on our children. We want them open if we can. But we said if they go up too high, as they did, they start to threaten the schools. The schools were not a source, but we had to close with much anguish. And now we've had to cancel, for most of the province, elective surgery. We really didn't want to do that. But we have to do that. And as Dr. Brown said, if you keep going, even getting access into ICUs and that will be challenging. So it's not just because of what you do personally, it's how you affect the whole of our community and about our provincial response. Again, I am very hopeful. I know that our Ontarians, for the most part, a lot of them are doing what they need to do. But there's more and more people are sort of saying, I think I can work around this and just play it by ear. A bad decision. And you need to be very careful in the next number of weeks especially. And I know if you do that, we all work together to do that, with mobility, sticking to public health measures, and getting vaccinated, we'll bend the curve on this one. And I think we can do all those things to get our hospitals back down, to give relief to the hardworking hospital staff that are there, to give relief to getting our children back into schools, and all those things to getting back potentially. I know you've given some dire projections about the summer. We still have some hope to get there, but that means everyone's going to have to do their part really well, really consistently, and very steadfastly over the next number of weeks especially. So thank you for what you're going to do, and we'll continue to do our part. And with that, I'm going to hand over to the media for questions.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
Antonella Artuso, Toronto Sun. Hello, doctors. Thank you. If we hit 10,000 cases a day, a not unlikely scenario in May or June under your modeling, what does our hospital situation look like? At what point does the triage framework truly kick in?
So thank you. And we are trying to work as quickly as we can, a large sector, and with the Ontario Health and with our health partners throughout to try and increase our capacity. So when you're getting up to 10,000 cases a day, and we're working at now, what is the hospitalization rate in there? It's fairly, it's higher than it was. We were looking at 6% before with the variants of concern. That's higher now. And that means if you do some arithmetic, those numbers start to exceed. So we need to be looking at capacity. We have our different areas we're working stringently at. Not only just beds, the key thing is human health resources. We need the staff to man those. And that's a major aspect there. So we have to look at all components to handle that. So I don't want to get to 10,000. I like the way those curves say we can bend it down. So in that way, as a real dire warning, we need to get that number bending and to bring it back down as soon as we can, because it will have implications. Do we want to put a triage system in place? No one wants to put a triage system in place. But in other aspects of pandemics, where large epidemics hit populations, unfortunately, there's large percentages of not only hospitalizations, but large percentages of deaths, more than we have seen in Ontario. We don't want to go there. No one wants to go there, but it is a reality. And you have to understand that that's what a pandemic does. But we can do it. We've done it before, so let's see if we can keep that down and not get to the 10,000. But we're trying to plan in case we have to. We have to do what we need to do when we have to do it. And that may not be a pleasant decision, but we're going to have to make that one.
Follow up?
Thank you. Did our good summer just disappear?
Well, I know Dr. Brown a couple weeks ago was saying with all things in line, we can look forward to a summer. Now he's saying the way things are, I'm not so sure. And they talked about high case numbers over the summer. That depends on a lot of things there. And I think if we could get that vaccination rate up to 300,000 a day, including if we put some stronger measures in, if we can get our vaccination rate, because I know in Ontario, we can easily do 500,000 a day, if not more, if we get the vaccine volume. And we continue to seek that, coerce for that, drive for that, and try to get that so we can get that kind of level up. And with that kind of level of coverage, we could have that available. But it's at risk right now. And that's what Dr. Brown and his data has alluded to, unless he wants to make some comment about that.
Maybe I'll just add to that. So under the scenarios we're looking at, if we had a very, very strong adherence to the public health measures, if we were able to really tamp down the spread of the virus right now, and if we're able to get as many vaccines as we can into arms, I know we can do 100,000. That's working out right now. 300,000 is a very optimistic scenario, but were that able to happen, you see very low case numbers by the end of June. You see really kind of that receding of the pandemic, and barring sort of things that are hard to anticipate around new variants, you could still see something of a summer. But it really requires everyone to pull together. It really requires as many avenues and vehicles as we can on the system level, and it really requires strong individual behavior.
Next question.
Lorenda Redekop at CBC.
Hi there. Thanks for taking my question. Looking at page 8 and those various curves, you said that we are right now basically along that yellow line. What would be a list of strong public health measures that would need to be taken to get us down to that green line, Dr. Brown?
Do you mind if I add something? So there's no silver bullet in any of this. There's no single measure we can put in place that will bring us down to that green line. But there are, I think, a series of things that would really help change. And I just want to sort of maybe stop here for a second. I think we all sort of hope that there was some magic combination of the minimum number of things we could do. The science isn't there, but what we do know looking at other jurisdictions, what we do know looking at our own experience here in Ontario, is that when we really put a lot of effort into this, when we really try to focus on this, we can bring the numbers down substantially. And so the first thing is doubling down that vaccination into the highest risk communities. That's where the most cases are right now. And it's because of the risk of exposure, because the people in those communities are essential workers. They can't work from home. Because the people in those communities don't have appropriate housing. They're crowded together. They can't isolate. Because they've got multi-generational households. And so it's just through no fault of those individuals, the risk of exposure is highest, and that's where you want to put the vaccines to help break that chain of transmission. So doubling down on that is really important. At the same time, more vaccination is really helpful. Second, we really need to make sure that workplaces are safe. There are going to have to be workplaces that are open. That's a primary area where spread will happen. So first, making sure that the list of what has to be open is as small as possible. Second, making sure that there's enforcement of safe workplace activities, that there's actually sort of observation to make sure that people aren't finding themselves in challenging situations that lead to spread. And there is a federal benefit for sick leave, but what we've seen looking, for instance, at the United States is that there's probably more benefit that would be helpful, and making that easier for people to access would be helpful as well, and help really prevent people from having to make a choice between paying their rent or putting food on the table and going to work. It's a terrible choice for anyone to be facing. Finally, we talked about workplace, talked about vaccination, limiting mobility. You've seen that there's been, Dr. Williams started to talk about this, there's been spikes in other provinces and some of the variants of concern. We're trying to keep those, the P1, B1351 under control here in Ontario. Limiting mobility into the province and limiting mobility around the province. I hate to say it at this point, there's emerging evidence that when you have a series of kind of patchwork rules in different communities, people tend to move, particularly to adjacent communities. We saw that in our own mobility data. When there was things open in one public health unit but closed in another, people moved over. So really limiting mobility within communities as well. So borders, but also within our borders, limiting mobility will help. And finally, Dr. Williams has said this repeatedly, but when we engage in the sort of simple precautions like mask wearing, 6 feet distance, really limiting our trips outside to when we're getting food or other essential goods or for essential tasks, that really helps bring it down. When we engage in good hand hygiene and all of these things. So the more that we do that, it's not just about protecting ourselves, it's about protecting the people around you and really helping the whole province get out of this as quickly as possible. I'm sorry that was a long answer.
Follow up?
Thank you very much. Is this the disaster that you were predicting 2 months ago? And could the government have prevented it if it had followed the modeling that you presented then?
The decisions about what government does are well beyond my pay grade in this. We've been anticipating a spike in cases because of the variants of concern. We started to put kind of a little box on our models to sort of show how we're doing now against our predictions. So yes, this is what we were expecting moving forward if we relax public health measures. And yes, the more that you can kind of keep, and as Dr. Williams said, not only public health measures in place, but adherence to the public health measures, the faster it tamps down. People, I think, often kind of look at it as some sort of trade-off, right? Have the public health measures or have the economy. Have the public health measures or have more opportunity for folks to move around and to live their lives. It's not a trade-off. Every jurisdiction has found itself, as cases rise, having to impose stronger measures. And sooner or later you have to do it. What I would say is that if we want to move forward with as good a summer as we can, the stronger measures we have in place, the longer we have in place for now, means that we don't have to keep on doing this.
Yeah, and I would add that I think in the process there is when we talked about it 2 weeks ago, there was recommendation then that we needed to put back down lockdown province-wide, and 2 days later we did. A week later, there was a strong recommendation to put it stay at home. 2 days later, we did. And each step along the way. But even then, the projections on the science table have been altered and changed as they saw the change in the presentation of the virus, as they understand more how it's impacting. it's a very dynamic thing because we are intertwined with other parts of the country and internationally as well, and we're seeing this impact in our society. So while there is an alarming rise in the numbers, and I don't want to scare people more than you need to, is that it can get a lot worse, even more worse than the modeler is putting forward. And other countries you can look at where that has happened. So we have to take it seriously and move ahead. Things can change very quickly. The modeling projections have changed week over week, and that's what we asked them for, to update and make it current, what was seemed to be the projection before. But it is interesting. 3 weeks ago, they said that now we'd have 600 to 700 ICU beds. But the cases were different. 2 weeks ago, they said 600 to 700 beds. Same number. But the cases are different. Now, a different one. So there's a different movement through, and we're seeing that happening. So we have each time looked at this issue in the face. We're looking at it now, and how do we go at this with the strong measures that we've talked to, and Dr. Brown just went over those again, and we can turn those numbers back down again. So my main concern is that people do not take it seriously. That is a major concern, and that does lead us into a more disastrous situation. We have to do everything together and do it stringently and do it carefully, and we can make it happen. We can turn it around.
Next question.
Jeff Gray, Globe and Mail.
Oh, hi, thanks. I wanted to ask just about the ICU projections, which, if I understand Dr. Brown correctly, a real catastrophe is just going to happen no matter what scenario, no matter what color the line is. There isn't another chart there that shows the effect of more vaccinations or more targeted vaccinations. Is there any way to avoid that, the numbers that are in that ICU chart, the 1,500 to 2,000 beds?
So in the very short run, the answer is no. The sooner we have strong public health measures and strong adherence to public health measures, the sooner that curve changes. The sooner we have stronger vaccination, more vaccination, the sooner that starts to change. But really for the next week or two, those numbers are baked in. That's not going to change. That's the nature of the disease. The cases right now that you see are the people who are going to be in the intensive care unit a week to two from now. So that's really set now. There is opportunity, though, to start bending it really following that period and avoid it. But that's where the measures and adherence, the uptake of vaccination and the number of vaccinations really starts to play in. It's not now, it's not next week, it's later on.
Follow up.
And to follow up, I guess, to Dr. Williams, the obvious question then, and the CDC did get it just a minute ago, but the whole point of public health measures to stop COVID from spreading was to stop the catastrophe from unfolding in hospitals of people being turned away who need life-saving care. It looks like that is an inevitability now. Is that not a failure? Did you not fail to protect the province from this?
So unfortunately, the quality of sound is jumbled, so I'm going to try and guess what I heard you ask about, that with the numbers projected with the hospital, the intensive care unit, and with the public health measures, I think you're asking that because it's going to be going up to the numbers projected and it's locked in on this, is that evidence of a failure? And it depends on what you mean as success. And one of the things that's very concerning to me is that there's very much a perception, a lot of people, is that if we are successful, we would have no hospitalizations and no deaths. That's not a pandemic, that's a nundemic. And that's not what we were anticipating. Unfortunately, we were anticipating that, and where our expectation was even higher, much higher than what we have now. We have done various steps along the way to keep bending the curve down in the face of new challenges, both within the changing of the actual virus agent and agents, plural, and with the changing of mobility of people and activity of people and their behavior. So we keep trying to bring that under control and bring it back down again. So the fact is that, and as Dr. Brown said, is there a magic bullet or a formula that will give you success? The answer is no, not really. It's a compilation of a number of things, and they're all moving at the same time. So there is no success formula. There is many things we can do to keep winning on this one and bring it down. But it is a real thing. There are going to be hospitalizations. And those hospitalizations, as Dr. Brown's alluded to, with the new variants, there's going to be a higher mortality rate than with the old one. We haven't seen that yet. In our other waves, most of our mortality, we saw cases, even with smaller numbers, of 80 to 90 a day. That was in our long-term care institutions. With our vaccination program right now, even this last while, the report today, they've had no deaths for over a week in the midst of all these high numbers. And in the retirement homes, it's very minimal. So we have moved that curve with vaccination. We're trying to get the rest moved at the same time. So there's no total success. There's ways to keep making it better and to keep bringing it down, and we have to keep working on that. And I am hopeful that we can keep driving it, and with seeking advice and ongoing updates from Dr. Brown on the science table and from our public health measures table, we will endeavor to do our part, but that means everybody has to do their part.
Next question.
From Jason Chapman, Global News.
Doctors, thanks so much for taking the question. I want to zero in on the patients that are in ICU right now. The question I tried to look up and tried to understand is how have those patients wound up in the ICUs? And my question is this, is what are the most at-risk activities that lead those patients to wind up in ICU? Do we have data on the most dangerous activities?
Well, I think that's an excellent question. Not just the activities, we're trying to understand what is the granularity, what are the risk factors that people are involved with. We're seeing that most of it, and still there are a lot of patients in the ICU are that over the age of 60. So it's not everybody's under 60. The concerning part is that we're seeing a shift and a movement, but still a lot of our patients in there are over 60. And our doctors in there are looking at each one and trying to assess, is there any pattern around risk behavior, risk activity, predisposing factors? And we know that there tends to be more males at the moment. We've seen more recently that pregnant women have been impacted by this third wave, as they were not so much in the first and second. And we're also seeing a younger age group. We're seeing still people with comorbidities. With issues like diabetes and other respiratory issues that are compounded by it. So we know those factors. But we're asking now in this third wave, are we seeing some other differences? How should we, as Dr. Brown's alluded to, how should we target our vaccine programs, not only just in the high-risk neighborhoods, but who are those high-risk individuals that we would want to identify and make sure that they are covered with vaccine as soon as possible? So I'm asking those questions because it is changing. And we need to be informed by our experts that are dealing with this in day out. And with these large numbers, we want to understand how is that shifting, how is it changing, and then how should we shift our priority setting to try and circumvent that impact on those individuals who is more at risk, and that the public can know, because then those at risk are going to really have to take precautions and be very careful with their exposure in the next 4 to 6 weeks especially.
Follow up.
Yeah, thanks so much for that, Doctor. Dr. Brown, you alluded to Thunder Bay being an area of the province that we should celebrate right now. They've been able to get high case counts down, and I'm presuming higher hospital rates down as well. So this is where I want to sort of drill down on, though. What did they do? Because it's my understanding that they did this essentially under the gray zone restrictions. So what measures did they take that we should celebrate and copy across the rest of the province?
Thanks. So, one of the things that I think they did, which is really important, is they intervened early. Thunder Bay, Dr. Williams, correct me if I'm wrong, but Thunder Bay sought to be put under the restrictions that they came under.
And thank you for bringing up Thunder Bay, my health unit where I've at for many years, and hometown and that. In one sense, when they saw the numbers rising quickly, we put them in the gray, and then they wanted to go into the lockdown, and we did that before we had it in place. And then we asked them to look at where the outbreaks were around. They quickly moved in to find out where the initiation was in certain centers, how that impacted their high-risk populations in the community. A lot of aspects were concerned around with the number of people we had with our urban Indigenous populations, how to move quickly. So they asked us for more help as far as case contact management. They asked us for more vaccines to vaccinate those high-risk populations, and they undertook to do that. And now 3 to 4 weeks after that, we're seeing the impact of that vaccination program, as well as they went in preemptively with the discussion with the boards of education to close schooling at that time because the amount in the community was so much. It was impacting that. So many steps were taken, serial on the way, not just one, and they assessed it as it moved its way through their at-risk populations and did a number of steps to stem that, and we assisted them from the province whatever we could. They still haven't seen, fortunately, the variants of concern yet, and we don't want to see that. But they have it under control right now, and we're going to keep monitoring and assisting them to keep those numbers down, as we've seen also with some of the others that we did in those early days, Sudbury and District Health Unit, as well as now we're seeing some improvements in the Lambton, as shown by Dr. Brown on his chart, with some of those areas that have seen improvements, and those were in the gray lockdown zone as well. But it tells you that with a concerted tempered response that fits that community, that the local medical officer of health and their team understand, and working with strong ties with community partners, all this works together to give a great response and to bring it down and hopefully to keep it down.
Last question.
Randall Denley, National Post.
Hi. As you mentioned again today, Dr. Brown, health measures take 2 weeks to come into effect or to show their effect. The current health measures have only been in place for a week. Is it too soon to say that they aren't working or will not work?
I think the rate of growth at this point is so significant that it would be a hard thing to wait this out and see whether or not they had more effect than they've had so far. We've not seen that precipitous drop in mobility. You can see it coming down, but it has not been as sharp as in previous times, and that mobility is a very strong predictor of cases. So I'd say the early indications that we have is that they're not working as well as we might like, and I think it's a very big bet or big risk to see whether or not they would over time.
Follow up, and this is the last question.
So you're recommending that there be an increase or a redirection, I think, of vaccine into high-risk areas. Would it also be your recommendation that existing appointments for lower-risk older people be canceled to provide that supply?
David, do you want to answer that?
So it's a fine balance, and it's made even more complicated with shortage of supply and delays in delivery of vaccine. And that's been perplexing to us and a great challenge to our vaccine task force to try and work this through, because we've got to race against time on two things. One, we know, as I said before, still a number of our people in our intensive care units are over the age of 60. And we still want to make headway. And we've seen improvements in our data and our hospitalization and ICUs around the over 80s. We're seeing some improvement now in our 70 to 79s. Getting there, we're trying to make some inroads on the 60 pluses. At the same time, as Dr. Brown's alluded to, we have our high-risk, so-called hotspots that we need to move on stringently and get in there and try and get that vaccine program carried out.
Maybe if I could add to that too. So, right from the start, or almost right from the start, the pandemic has been incredibly inequitable in our province, as it has been virtually everywhere else in the world. What we're dealing with now is we have a tool to help fight the pandemic, which is vaccines. We need to use that tool to really correct that inequity. And, if it came down to a hard decision about where to really put those vaccines to get the impact, by any means necessary, I'd say, because it's really critical to get those vaccines where they're going to have the biggest impact.
And I think the point I was trying to make earlier, and this is where it comes into. If there's a high-risk group, even though you say as a X-year-old, I should be next on the list, if there's vaccine diverted to go to that group, I would hope you would have and say, well, we haven't got much in our area. I can do the things because I have the ability to, either due to my position or influence, affluence, I can keep myself unexposed. There's some people due to essential work stuff or reasons, they're unable to do that. And I would hope you'd be able to say, well, I'm disappointed that I can't get something right away. At the same time, I understand why that's necessary there, but because I know I'm going to get mine anyways. And we are trying to get both done at the same time. We'll do that as best we can in there. But it's the same as if there was someone who was in more dire straits, say to get seen in the emergency department, you say, I think they should go first. even though I would like to get seen on my issue, I think they're in more dire straits. So we want that. That's that Ontario civic responsibility type response. We need that right now more than ever. We don't need to be judgmental of each other. We need to be more understanding and trying to see the best, because we're in this together, and together we can solve it.
Thanks, everyone.